Okay, so I've given you a number of basically bone lesions that are probably some of the more common, or if not common, at least critical for understanding and being able to sort of diagnose. When possible, if a frozen was performed, I gave you the frozen because often with bone lesions, that's how diagnoses are initially suggested. Whereas, a lesion is identified, they want to do a definitive procedure or not. And depending on what the results of the frozen are, a definitive procedure may be done if it's a benign process, and a definitive treatment will be delayed if it's a malignant process, right? So always remember with bone lesions that the frozen is critical. And if you are ever uncertain if something is, oh, there she is, good. If something is benign or malignant, always defer, because if you call something that is actually malignant, if you give it a benign diagnosis and they curettage, they contaminate the field and basically preclude the patient from having limb sparing surgery in the future, right? So they more often have to do an amputation then. So that's the one reason why frozen is so critical. And if you're uncertain, defer. So back to that, when possible, I've given you the frozen, and then I've given you follow-up permanents as well as in relevant cases, immunostains, which were not on the presentation that I sent out to you guys, but will be on this final presentation, which I will send out once we're done. If we get through all the cases today, great. If not, we'll finish them next week. All right, so without further ado, does anybody have any questions or comments before we start? Okay, so this first case is a 17-year-old male who has a lesion in the right radius. And so, Heather, are you able to discuss the radiology here?
Sure can. So side by side here, I've shown the X-ray where it's a little bit hard to see. So I've put like a little red box around the lesion. It's this little tiny round, well circumscribed guy that's like sort of lytic around the outside, and it's got this nice sclerotic sort of nidus in the center. And this is pretty classic for what we're about to see on the slide.
Awesome. So to recapitulate, the lesion is basically right there.
Yep.
And yep. And I guess, is this the same patient?
Yes.
Okay.
Yeah, the one on the side is a zoom up on the CT, but yeah.
Oh, I see.
I think I might have flipped it.
Yeah, no, it's fine. Because in this case, the hand is at the top, and in the image on the right, the hand would be at the bottom. So the humerus and the radius and ulnar just flipped. Okay, no, I got it. So cool. So there's the lesion there with a little pallor and then sclerotic area and then pale rim. Okay, cool. So anybody want to tell me what they saw on the histology? First of all, what's this?
This is bone trabecula.
This is bone. Thank you. If nobody talks, I'm just going to start really basic. So you all better speak up. So this is bone. Is this lamellar bone or woven bone?
So this is, no, it's not woven bone.
Like nice lamellar bone.
Exactly. It's got beautiful sort of lines running through it. The osteocytes are very small, and I do not really see osteoblast rimming. So what does this imply?
Dead bone.
Pardon?
Dead bone, or.
So how do you know whether bone is dead or alive?
It looks like there are osteocytes in the lacunae, so presumably it's alive and well.
Correct. And so what is excellent? So it's a live lamellar bone. What does a live lamellar bone imply? Is this lesion or is this?
No, this is not a lesion.
Right. Presumably this is probably some adjacent normal lamellar bone, because most bony lesions produce the bone, and the bone begins as more of an immature type of bone. So, okay, looking around, what do we have here? mature bone or woven bone?
Not lamellar bone.
Right, not lamellar bone, right? So you see very fine lacy osteoid without very discrete parallel lines. Maybe you see some intersecting sort of lines, but not much. The osteocytes here are also present in the lacunae, right? So this is also still viable. And if you are, keen, you may identify some small cells kind of lining up here at the edge of the bone. What is this called?
Osteoblast.
Osteoblast rimming.
Osteoblast rimming, beautiful. And maybe you see one of these guys, which is a
Osteoclast.
osteoclast or osteoclast-like giant cell. Excellent. So I just figured out that Path Presenter can do polls, but I didn't embed it in your previous presentation, so I apologize. I'll do that next time, because when you preview the case, then you could actually select what your preferred diagnosis is. So if anybody has any thoughts based on at least what I've given you in the potential options, or based on your own options of what this is based on the radiology and the pathology, can you let me know verbally or in the chat what you think it is? You said C, meaning osteoid osteoma. Yeah, so tell us about osteoid osteoma, Ryan or Perry.
Pain at night relieved with NSAIDs, young adult.
Mm-hmm.
But yeah, kind of has that lytic with the the nidus in the center.
Mm-hmm.
I don't know. I'm operating more on buzzwords than anything else.
Yeah. So in this case, the buzzwords are true, right? So present in the cortex with the little nidus, night pain cured by NSAIDs, usually younger males, exactly. So in this presentation, I've put for you my sort of bullet point slide about these. And so, basically what you might get on biopsy, quote unquote biopsy, is minimal, right? So as you saw here, a ton of this is sort of just junky lamellar bone with, I would argue that this stuff in between is basically just dust, bone dust and debris, but the actual lesional component is sparse. Why is the lesional component so sparse? How do they treat these?
Cortage, they do.
So if they treated them with curettage, we might expect to see a little bit more of the lesion.
Do they ablate some sort of
Yes.
ablation?
Yes, they radiofrequency ablate. And so often when we get, lesional tissue, it's either nothing or very, very sparse. And so they're not actually resecting it in these days or curetting it, they're just burning it basically with radiofrequency. So we were lucky enough, and I think this was a bit of an older case, we were lucky enough to actually get the osteoid osteoma here in this case. But in today's day and age, you may not actually see any lesion because they core through the cortex, they ablate it, and then they send you whatever fragments are residual. So don't be surprised if you don't really see much. Your differential diagnosis of an immature bone forming lesion that is benign might be an osteoblastoma, in which case, the clinical presentation is somewhat different. The lesion is larger. The location tends to be a little bit different as well. Although it can also occur in the long bones. Osteoid osteomas also like to occur in the vertebral bodies. They can also occur in the mandible. And they tend to have somewhat larger, more plump osteoblasts with these sort of perinuclear large HOFs. So that might be on your differential. Of course, on all of your differentials with all of these is some kind of malignant bone forming lesion, but we will discuss that as we go. Questions or comments? All right, 18-year-old fibula, right side.
All right, so unlike the last one, you actually see like kind of a larger lytic lesion that sort of buckles the bone outward here. It looks kind of worrisome on X-ray. it's sort of ISO intense on T1 and a lot brighter on like more fluid intense on T2, and it's sort of heterogeneous. And they didn't have like a nice coronal image for the contrast, for the post contrast one. So I kind of drew a dotted line and gave you the level. And so you can kind of see heterogeneous enhancement, but more importantly, you can see these 3 very dark flecks in here that have sort of the same intensity level as bone. So you know that they're like big, thick, kind of bony trabeculae in the middle.
Awesome, thank you. Yeah, so it's always, I always get, confused with radiology. So for me, it's always helpful to look at the sort of characteristics, like Heather said, of the normal tissue. And so, normal cortical bone is black, with sort of the muscular tissue being more gray, the lesion being quite enhancing, and right, exactly, these black kind of comma-shaped flecks here being reflective of the exact same intensity of the bone. So in this case, a frozen was sent. So we have basically a lesion, right, that's sort of bowing out the bone, but perhaps not overtly destroying. You can still see that there's probably some sort of thin rim of cortex on the outside. So it's not overtly invading soft tissue, but it is sort of bowing out the bone. Does anybody want to describe what they see or suggest differentials? Faiza says bland spindle cell lacking atypia. Scant, giant, some kind of fibroosseous lesion. Question mark fibrous dysplasia, non-ossifying fibroma. So I'm just going to drive around a few seconds here just to remind ourselves of what the morphologic features are. So multiple fragments of arguably bland spindle cells with interspersed small little cores of bone, right? There are actually small little cores of bone here. The bone, again, seems to be immature or woven. Do you see osteoblast rimming? No, not really, not to the extent that we saw in the prior case. So in this case, monotonous sheets of spindle cells without significant atypia, with small cores of bone, without osteoblast rimming. At least on the frozen section, do you want to vote benign, malignant, or don't know? Benign. We have 1 vote for benign. All right, so here's the permanent section. Another vote for benign. Excellent. So yeah, so this was called benign on frozen. And here are the confirmatory permanent sections. I will point out that of the things that you have discussed, the diagnosis here is going to be fibrous dysplasia. And so, when you think about a fibroosseous lesion of bone, there are a few things, I think you guys all picked out some good differentials that come to mind. And so one, I'll start with non-ossifying fibroma. So non-ossifying fibroma tends to have a little bit more storiform appearance, with intersecting short fascicles, almost like a dermatofibroma or a fibrous histiocytoma of bone. That's how I like to think about that. Really without bone, right? Without much bone. In this case, the bone is very sparse, but it in fact is there. It does appear to be woven, hence lesional. All right, so not really storiform, bone is present. The bone in this case, right, is sort of just ossifying right out of the background tissue without too much osteoblast rimming. And so this type of just kind of appearance of bone right out of the spindled stroma is very characteristic for fibrous dysplasia. Here's my slide on it, it's loading. All right, so radiographically, characteristically, this so-called ground glass lesion, right, with this remaining sclerotic rim of bone that bows out the bone. In some circumstances, it may be bone poor, right? So if these things are around for a long time and they start to mature, you may actually not get much bone, which is the case here. So if you have a predominantly fibroblastic lesion with minimal bone, fibrous dysplasia is still okay and is still on your differential. Here's a nice trabeculum here. What other than NOF and fibrous dysplasia, what should always cross your mind in a younger person with a fibroblastic / osseous lesion, what is one thing you want to exclude?
Like a low-grade osteosarcoma.
Right, like a low-grade intramedullary fibroblastic osteosarcoma. So I would argue that, this is probably your most important differential diagnosis with fibrous dysplasia, such that it's composed of fibroblasts, bone in the background. The bone in these cases can either be woven or lamellar in these kind of long, very long kind of parallel trabeculae. However, you should see some atypia. Even if it's a cell here and there that's enlarged and hyperchromatic, even if it's a mitotic figure here and there, look closely in the background for those features, because that might point you to a direction of low-grade osteosarcoma, in addition to the radiographic findings. So don't ever lose sight of that, right? So no breaking through the cortex, no aggressive features in this case would be compatible with a more benign lesion. Anything that's breaking through the cortex with fuzzy borders, think about osteosarcoma. One great thing is we can do stains for MDM2 CDK4, because just like some of our fatty lesions, these actually have chromosome 12 MDM2 amplifications. And so you can throw an MDM2 CDK4 stain on there. And if it's positive, you might suggest osteosarcoma. So, another reminder of for bony lesions, I harp on this every time, right, though, is decal. And so you never know when we're going to need an immunostain or a confirmatory molecular test. And so always have EDTA decalcification right up there for bone biopsies, because we may need to perform things like immunostains and confirmatory molecular as we start to know more and more about the molecular basis of bone lesions. So just keep that in the back of your mind. You guys mostly are pretty good about that now. Okay, questions? All right, 12-year-old male has a lesion in the right talus.
All right, so the X-ray here is not quite the best. It's actually a cut-through CT. So I chose a cut-through CT here. It's kind of like this very well circumscribed, but clearly bone-forming lesion that's like sort of taking up a lot of the talus. It's sort of iso-intense to like muscle on T1, and it does show some heterogeneous enhancement. And like if you look at the outer rim of the lesion, like compared to the bone, it's kind of fuzzy, it's ill-defined, and it looks like it could be infiltrative.
Awesome. So a bit of a challenging case here. So we have an intraosseous lesion with perhaps some maybe suggestion of an infiltrative border, but still mostly contained within the talus. So I'll drive around here. I can put my poll up if you guys want to take a look at what the options I've come up with. But either type in the chat or let me know what you guys thought. Again, this is a frozen section. Real-time case.
I thought it was an osteoblastoma.
Okay. Can you tell us why? That's a good thought.
So I was going more, I guess, towards this epithelioid variant, or I don't know if it's necessarily a variant, but there's just these epithelioid cells that are super plump and eosinophilic. I wish we had, I guess, more tissue or more bone to see if what is described as this very well demarcation between sort of malignant and non-malignant bone. But
All right, so you've at least identified that it is bone forming, right? So if you're thinking, you said osteoblastoma?
yeah,
Yeah, so you've at least identified that it is bone forming. There's actually quite a bit of crunchy, chunky, kind of immature looking bone here with these very plump cells in between the bone. So a bone forming lesion is certainly on the differential. We have a few comments saying malignant. So those of you guys who said malignant, can you tell me what your thoughts are on that?
The cells are large, hyperchromatic. I'm able to see, I think I saw kind of mitosis. Yeah, they are pleomorphic. So yeah, so it's malignant. It's if it's bone forming tumor, so I would go with sarcoma. So osteosarcoma.
Yeah, so yes, so it is osteosarcoma. I'll go through the permanence and we'll discuss why. So this was an extremely challenging case for a few reasons. One, because clinically the context, the radiographic features were actually quite suggestive, not of a osteoblastoma, but actually of a chondroblastoma, which let me pull up my chondro. Oh, shoot. I didn't put it in here. Sorry. Or is it at the very end? Nope. Okay. I forgot my chondroblastoma slide. Anyway, so there was a suggestion clinically that this might represent a chondroblastoma, right? So chondroblastoma can have calcification. So this sort of chicken wire calcification that might resemble some of this sort of lacy osteoid. But what we are missing for chondroblastoma are the sort of small, bland cells with wrinkled nuclei. We're missing the osteoblast-like giant cells. For osteoblastoma, as was suggested, I agree that we're probably cytologically more atypical than either an osteoblastoma or a chondroblastoma. But the atypia isn't, I agree, it's not sort of hit you across the head pleomorphic, right? It's just, if you look at the fine, subtle nuclear features, you will see that these are plump ovoid cells, occasionally with nucleoli, occasionally with some dark chromatin, but with very sort of, I don't know, oddly like wrinkled contours, very much overlapping. Maybe there's a red nucleolus in there. It's a little bit hard to say, but here's a very hyperchromatic cell. Here's another hyperchromatic cell. And oh, yep, that might be a mitosis right there. Actually, there might be two in this field. Maybe, that's hard to tell. Maybe that's another one. So it's areas like this that you really should step back and say, okay, look at those nuclear features. If they're enlarged, if they're wrinkled, if they have nucleoli, if they have this suggestion of either mitosis or karyarexis or apoptosis, take a step back and say, all right, is there any way this could be an osteosarcoma? And so we deferred diagnosis on the frozen because we were concerned that this did not match the clinical correlation or the clinical suggestion of a chondroblastoma. And so here's the permanent sections from non-frozen tissue that have been processed for permanent. So very, very fine, lacy osteoid. And maybe the atypia comes out a little bit more on the permanent sections, such that you can see these random dark hyperchromatic cells that are kind of punctuating the background of the osteoid. And let's see. Just gonna look. Yep, enlarged and dark, enlarged and dark, enlarged with nucleoli. And so, oh yeah, actually here's a good area, right? So there's a randomly enlarged one. There's a nice randomly enlarged one. And so not only there's diffuse sort of nuclear enlargement, but there's also this interspersed kind of patchy random hyperchromasia. And so, you know, when we talk about, you'll always hear me say in thyroid, parathyroid, right? Random endocrine atypia, random endocrine atypia. Well, this is not random endocrine atypia. This is not an endocrine lesion, right? So when you, in a mesenchymal lesion, when you see this random popping out atypia, actually we should be quite concerned. Okay, in the clinical question of a chondroblastoma, if this were a clinical question, which it was, of a chondroblastoma, does anybody know the one ancillary test that we could do to evaluate for a chondroblastoma? All right, thank you. So yeah, histone. So let me pull up the slide. So, oh yeah, I did have it here. So histone 3, specifically the K36M mutation, is present in chondroblastoma. So I did have my chondroblastoma slide in here, sorry about that. So here is what a classic chondroblastoma looks like, where you could imagine that this very fine chicken wire calcification in the background might resemble that osteoid. You certainly should see some kind of cartilaginous elements in a chondroblastoma, which we didn't see in ours. And the nuclei are usually small and round to ovoid and kidney bean shaped, but not hyperchromatic, enlarged, atypical, right? They're very, very monotonous. And so we did the histone K36M mutation, which is a send out to Mayo on the actual live case. All right, so this is the positive control plug, all right, showing you nuclear reactivity. And this is the patient's tissue. So we've successfully confirmed that the clinical suspicion of chondroblastoma is not in fact the case, and we've more correctly made a diagnosis of osteosarcoma. So, you know, if you're lucky, right, you'll get the classic Codman's triangle with the bowing out of the periosteum. If you're lucky, you'll get super enlarged, hyperchromatic, mitotically active lesions. Sometimes you have to search for osteoid, right? In our case, we had a ton of osteoid and we actually had to sort of look beyond it to find the nuclear features of the lesion. So that was a challenging case of osteosarcoma from a frozen section. Does anybody have questions or comments? Okay. All right, 15-year-old male, right shoulder.
Hello. Okay, so here too, you see kind of like this destructive sort of cystic lesion, both on the X-ray, and you see it a lot better like on the MRI that I've shown over here, where you have kind of like this multiloculated cystic lesion that's kind of like sitting right here in the cortex of the bone and possibly destroying it. It's, I don't know, it's not entirely classic for what we're about to see, but it's pretty darn good.
That's, you know, that's the thing with bone, right? It's never entirely classic. If it is, they wouldn't biopsy it. No, I'm just kidding. All right, so excellent. So a large lesion in the shoulder of this young person, you know, youngish, 25 male. So somebody's already previewed FISA and is suggesting ABC. So tell us what you saw. Perry says non-ossifying fibroma. All right, let's start with FISA. Tell us what you saw.
So I was with Perry the entire time until I just got to know that this was like it appears cystic. That's the first thinking that I have in my brain when somebody tells me that it's a cystic bone lesion, and I see like osteoclast like giant cells,
Mm-hmm.
and then like blend like fibrostroma with like some vessels.
Mm-hmm.
So that's why I jumped on ABC, because I thought that now it's going to be ABC. It's not going to be non-ossifying fibroma.
Mm-hmm. Yeah. So first, we're in a little bit of an odd location for an NOF. What might be a more classic Lemming? What might be a more classic location for an NOF?
Like the like femur, like long.
Yeah, like the cortex of long bones. Exactly. And so one, it's an odd location. Two, it's quite large. And three, yes, there was some suggestion of some cystic change with maybe a line right there and maybe a line right there, which is, buzzword fluid level. And so we're going to also talk about exactly buzzword of Lemming. So yes, non-ossifying fibroma and what this turns out to be, which is a solid aneurysm, or relatively solid aneurysmal bone cyst, both have osteoclast-like giant cells, both have fibrocellular stroma. Arguably, the stroma in the background here, would you describe it as a little more tissue culture-y, or would you describe it as more storiform? Does it have nice sort of tight interlacing, carpet fascicles, or does it have a little more haphazardly arranged cells?
Oh, it's more haphazard.
Yeah, so that's one like soft sign. These more haphazardly arranged fibroblasts that are sort of pointing in all directions with very wispy cytoplasm is good for that, for the background in ABC, rather than those more tightly packed, curvilinear fascicles. We do see some pale pink osteoid in the back here. That's totally fine for this lesion. The other thing that we see in the background is right here. So very occasionally and very rarely, you might get this so-called blue bone. So in aneurysmal bone cyst, sometimes you get, just characteristic eosinophilic osteoid, but be mindful, right, that the cells within it are not atypical. They're small, they're crushed almost by the osteoid, as opposed to being malignant appearing. And sometimes the bone in ABC is blue, as here, almost kind of purplish blue calcified. So that's another soft sign. Remember that these can be mitotically active. You see a couple of mitoses here. And Ryan, did you see lemmings jumping off the cliff?
Yes.
Maybe there's a couple right there, right? So the osteoclast-like giant cells, if you're lucky enough to be at the edge of a cystic space, can be seen to sort of be at the very edge of the cystic space, almost jumping off into the cliff like lemmings. Exactly. So we got in this case much more of a solid core of bone, but you do get the suggestion that there may be some lemmings jumping off into the cliff. You do get that kind of, I'm going to say it, nodular fasciitis like stroma, right? Where you have these haphazard fascicles. You have even some, where did I see it? I saw some nice extravasated red cells. Yep, out here, right? So that same nodular fasciitis like stroma that you see in true nodular fasciitis, you see in this lesion. And what is the unifying factor of both of those? If I haven't drilled this into your brain yet.
USP6.
Yes, excellent to both of you guys. USP6. So nodular fasciitis like appearance in bone. Always think about aneurysmal bone cyst. It doesn't have those tightly packed storiform fascicles. It may or may not have the classic fluid levels, dependent on whether it's solid or cystic or both, dependent on in which direction the patient is lying recumbent on the on the bed of the imaging. The fluid levels are going to match the direction of recumbency. And so here's your classic example of cystic aneurysmal bone cyst. We see blue bone here. We see the lemmings jumping off into the cliff like, pew here, pew here. But USP6 fish can be confirmatory if the case is ever questionable. So again, another reason to not decalcify things if this is significantly osseous. This was not very osseous at all, so it didn't even need decal. But that's ABC. One thing I will point out is, in a young person with cystic bone, what are your differentials? So one of the things you may want to consider is a telangiectatic osteosarcoma, which can also present in a young person with cysts, with fluid levels. But, again, looking beyond, you should see significant hyperchromasia, enlargement, atypia in the walls of these cysts, not just those nice storiform, spindle cells. So this is an example of telangiectatic osteosarc. Other non-malignant cystic bone lesions might include a unicameral bone cyst, which doesn't have as much of a cellular background. It has more of this almost ropey, eosinophilic, collagenous wall, still with maybe an occasional giant cell, but much thinner walls, much less fibrous tissue. You sometimes get intraosseous ganglion cysts in the setting of osteoarthritis, right? That they just look like subchondral cysts or ganglion cysts. Don't forget that on rare occasion, you may get an epidermoid cyst in the bone, which is, exactly as it sounds, lined by squamous type of epithelium. So those are the types of cysts you may want to consider in bone. Questions, comments? All right, next we have a 22-year-old female with a right tibial lesion.
Yep, and you'll notice that in contrast to our other guy, to our first guy, this one is a lot more solid appearing, both on the X-ray and on the MRI. And again, it's actually pretty much iso-intense to muscle on T1 already. So it's kind of hard to argue whether or not there's enhancement, but it does look like it brightens up a little bit. And again, you can see like these kind of like coarse, kind of black speckly calcified areas that have the same sort of intensity as bone does.
Awesome. So here's a nice, large specimen for you guys to look at. I love it when you have so much tissue, right? So if you don't know what this is, burn it into your brain. Giant cells. Okay. So large osteoclast type giant cells with many nuclei. Okay. The giant cells are arguably, if you look on low power, somewhat quite evenly spaced, right? Like you just see, sprinkled, nice, evenly sprinkled giant cells just diffusely throughout this lesion. Everywhere you look, they're sprinkled. They may be somewhat challenging to see because they can sort of blend into the background, right? And so sometimes you have to actually go on higher power to say, oh, okay, those 6 nuclei are the giant cell. Those 6 nuclei are the giant cell. Those 6 nuclei are the giant cell. And then there's individual, right? Individual, all these individual cells in the background look very similar in terms of their nuclear morphology to the actual nuclei of the giant cell, right? They're all sort of ovoid with some open chromatin with maybe a small nucleolus here and there. So in this case, your diagnosis, some of you have already said it, thanks, is giant cell tumor of bone. In giant cell tumor of bone, what are the neoplastic cells? The mononuclear cells, the giant cells, or both? Excellent.
Mononuclear.
Excellent. Mononuclear cells. So the giant cells are bystanders, but they are in fact what the tumor is named after because they're so prominent. They can have nuclei in excess of like 50 nuclei per single giant cell. So don't be surprised if you see giant cells in giant cell tumor of bone. One item I will comment, is that in any giant, oops, I'm just gonna get this other thing on the side. In giant cell rich lesions, just going back to our aneurysmal bone cyst, for example, comparing side by side, how the giant cells are arguably somewhat more sparse. When they are present haphazardly. They're not present in a nice diffuse sheet-like arrangement. Yep, like there's one, there's one, there's one, there's one, there's one. But you can get secondary aneurysmal bone cyst change in really any other bony lesion. And so one of the more common lesions to get secondary ABC-like change is giant cell tumor of bone. But in order to make the definitive, I mean, in this case, it's obvious, but you should see some residual background lesion in this. Oh, there's a nice big one. In this case, a giant cell tumor. And if you see something that has aneurysmal bone cyst-like change, if it's USP FISH negative, that could mean that it's secondary ABC-like change in a background of something else. So this is a classic example of giant cell tumor of bone. We don't often see these, as in this case, resected, like on the right. They're generally curetted, as we saw in the above example. On occasion, if they are refractory to therapy or aggressive, they can be resected en bloc, but more often they're just curettaged. And so this is the other lesion that has histone mutations. In this case, it's the G34W, which is also a nuclear test, which is also a send out to Mayo. In this case, I thought it was nice because you can see that the background mononuclear cells are the ones that have the nuclear expression, and the giant cells are negative, right? So the giant cells do not maintain this histone mutation, again, confirming that they are not the neoplastic cells. They can be treated with rank ligand inhibitors, i.e. denosumab. And when they are treated with rank ligand inhibitors, they sort of, it's the rank ligand interaction between the mononuclear cells and the giant cells that sort of induce or recruit, I should say, the giant cells. And so when you block that interaction, the giant cells go away. And so in treated giant cell tumors, you will see loss of osteoclast-like giant cells. You will see retention of background mononuclear cells, and you may even see just diffuse maturation to an almost fiber osseous-like lesion, which, in your mind might look like a fibrous dysplasia, might look like a low-grade fibroblastic osteosarcoma. So always find your history. If this person had a giant cell tumor treated with denosumab, this is an appropriate treatment response. Once you take the denosumab away from the patient, it reverts. It goes back to your classic giant cell tumor. So this is not a cure. This is a sort of temperative treatment. Questions, comments? All right, excellent job, guys. So we have about 10 minutes left. Now we have a young person, 2-year-old male, left femur.
Oh, okay. So here, you can see a fracture, and like under that, you can see this kind of like lytic lesion that is pretty well circumscribed. And well, the fact that it's lytic doesn't imply that it's destroying bone. It doesn't necessarily look like it actually infiltrates out of the bone or into the soft tissue around it.
All right, so especially in a kid, we have a frozen, because if we can come up with a benign diagnosis, they can stop. And if we have to come up with a malignant diagnosis, they might pause. So here you have a frozen section. Anybody I'm just gonna move around. This doesn't look very nice. I'm gonna go to the other area. Anybody wanna describe what they see? Lesional or not lesional? First of all.
Lesional.
Lesional. What might the lesional cells be? Or at least what is their appearance? Round cell tumor. Not some sort of histiocyte. Ewing. So we have a couple of votes for a round cell. I'm gonna include round cell and Ewing's together. Then we have some kind of histiocytoid lesion on the differential. So Perry, what made you think about histiocytoid?
I thought I saw maybe some like grooving in some of the nuclei, and I saw maybe a couple of EOs like floating around, although I might have been totally hallucinating those. It was late last night. I don't see them now, so I think I was probably imagining them. I mean, it doesn't really look right for a Langerhans cell, but I don't know. That was sort of bouncing around in my brain.
Looks
I
like
don't know.
Ben agrees with you. Mononuclear, eosinophilic, groove nuclei.
Well, that's heartening.
Yeah, so clinically in this case, in fact, the differential was really between a Langerhans eosinophilic granuloma type of lesion and a round cell tumor, right? And so especially in a young kid. So I would argue that I agree with those who saw these grooves, these wrinkles, these almost fetal or kidney bean. There's actually a couple perfect ones right there. That have they're plump. They're sort of plump and juicy. They do have these. Oh, there's a nice one. Kidney bean shaped nucleus. For a small round blue cell tumor like a Ewing, these are honestly kind of too big. They're a little too big. They're a little too open chromatin. They're a little too wrinkly of the nuclei. For a true round cell tumor differential like a Ewing's or like a rhabdo, your cells are probably going to be somewhat smaller without this nuclear folding and wrinkling. That's a really nice one right there. Literally round nuclei, right? Like literally round. It's hard to make out EOs on frozen section because because the eosinophilia of the cytoplasm is not as rich as it is with the standard H&E. But if you start to see, inflammatory cells that have two lobes, that's a good sign of an EO. Eosinophilic granuloma / Langerhans histiocytosis, yes, should have some EOs in it, but sometimes it's got neutrophils or other inflammatory cells. But the bilobed nature of the EOs might be visible occasionally if you look very hard. And I think there's at least one in the middle of this field. So we were able on frozen to exclude that this was not a small round blue cell tumor. Let's look at the permanence because that might be more obvious. But to those of you who thought about EG, well done. Maybe now it's a little more clear, right? So unfortunately, the eosinophilia, again, of those EOs doesn't show up quite well on frozen. But if you look at the nuclear features here, oh, look, there's a little osteoclast-like giant cell. If you look at the nuclear features here, they do recapitulate what we saw in the frozen, right? With the kind of wrinkled kidney bean. Oh, there's a nice kidney bean shape right there, grooves. Sometimes they have kind of perinuclear Hoff type cytoplasmic changes. What immunostains do you want to confirm? Oh, look, these are beautiful. These sort of like half wreaths.
Could we get like an S100, Langerhans, CD1A?
Sure. Oh, look at all those EOs there. Look, now they come to us. Okay. So whether you've ordered a CD1A or a Langerhans or an S100, here's your answer. This, I believe, is a CD1A. I didn't scan them all because they all kind of show the same thing, but those 3 markers are going to be specific to your Langerhans cells and really should not be present in regular, just histiocytes. Sometimes, now this is pretty dense. I was going to try to see if there was any kind of their little accentuation, maybe. All right, so that's your CD1A. Excellent. What else do these tumors have genetically? What's their driver in many instances?
They have BRAF
They
mutation.
have BRAF. You want to see a BRAF stain?
Yeah, I do.
Yeah, I do. Look, it's beautiful. It's positive. You know how I feel about BRAF. It tends to be quite a weak stain, but in BRAF mutated neoplasms, like Langerhans histiocytosis / eosinophilic granuloma, pretty much every single background cell should be positive, and the inflammatory cells, of course, will be negative. But this is a BRAF positive, BRAF mutated case. So I thought it was a very lovely example of a classic EG / Langerhans histiocytosis. As a reminder, right, this is the classic slide for Langerhans. Remember, well, you've already taken your boards, but for those who are taking your boards next year, I don't know if they still ask for electron microscopy, but the characteristic tennis racket shaped Burbeck granules that are present in the cytoplasm of these cells. All right, what else? Questions, comments? I'm not going to belabor it since we've already kind of.
Yeah, Dr. Cipriani, how
Yeah.
specific or how sensitive is that BRAF, IHC, and Langerhans cell histiocytosis?
Yeah, so in general, I'm going to take a step back. I'm going to say if you have a BRAF V600E mutated lesion, it is excellent. So whether it be melanoma, Langerhans, thyroid, it's quite good. The only issue is if you have if your lesion is not mutated, or if your tissue is like decalcified, for example, those might be limitations, right? But if you in fact have a BRAF mutated lesion, it's great. The fact is that not all EGs, not all melanomas, right? Not all thyroid cancers are BRAF mutated, right? So if it's negative, you could probably trust that it's not BRAF mutated. And if it's positive, even if it's weak, it's still quite good.
Okay, no,
Yeah.
thank you. For
Yeah.
some reason, I remember reading something about the IHC wasn't very good, but now that I think about it, that may have just been hairy cell leukemia. So.
Okay. Yeah, I mean, I haven't done it on many EGs, honestly, because we don't get that many. But my understanding of the immunostain itself is that it's quite good. At least in our lab, it's been good. Yeah.
Yep, thank you.
Yeah. All right. Yeah, how many hairy cells are BRAF mutated?
Almost all of them.
Huh. And the stain doesn't work well in those?
I'll have to look back into that.
Okay.
Yeah.
Yeah, let us know. Is it V600E or is it some other BRAF?
I'm pretty sure it's V600E.
Okay.
Yeah.
Cool.
No.
Yeah, let us know.
I'll look into it.
Okay. Other questions? All right, 19-year-old male, tibia left. Oh, it's 8:57. Should I let you guys go and do the rest of these next week? Or should I rush through this last case in 3 minutes? It's not the last case. I have 1, 2, 3. I have 3 cases left. Down in heme, we get pimped on BRAF V600E for hairy cell. Okay. Well, in the theme of not rushing, I won't rush through that next case because it's a nice one. I'll let you guys go a couple minutes early. So thanks. If you have any, I like 10, it's easy. If you have any lesions that you want to see in comparison for next week, let me know and I can try to throw some slides in. If there's anything that we missed that you're confused about, maybe I'll try to find an NOF.